What if I told you that your nervous system has more to do with your endometriosis pain than you probably think? And what if I told you there's practical tools in place that can help you with your pain management? Have you ever heard of neuropelviology? Maybe you even heard about fight or flight or rest and digest and the vagus nerve. Professor Marc Possover is joining me today to go over that and so much more. So stick around. Welcome to Endo Battery, where I share my journey with endometriosis and chronic illness while learning and growing along the way. This podcast is not a substitute for medical advice, but a supportive space to provide community and valuable information so you never have to face this journey alone. We embrace a range of perspectives that may not always align with our own, believing that open dialogue helps us grow and gain new tools. Join me as I share stories of strength, resilience, and hope, from personal experiences to expert insights. I'm your host, Alana, and this is Endo Battery, charging our lives when endometriosis drains us. Welcome back to Endo Battery. Grab your cup of coffee or your cup of tea and join me at the table. Today's guest has built his career on a bold but vital belief that suffering pain should not be a life sentence. And for Professor Marc Possover, that belief isn't just a philosophy, it's a mission. As a world-renowned pioneer in neuropelviology, yes, you heard that right, he has transformed how we understand and treat chronic pelvic pain, especially when the source is elusive or deemed untreatable. His work bridges the worlds of gynecology, neurology, and minimally invasive surgery to target the pelvic nerve directly, often bringing relief to patients who've been told to simply live with it. Professor Possover isn't just treating symptoms, he's finding the root cause, especially in cases involving nerve entrapment, endometriosis, and neuropathic pelvic pain. His methods have given hope to countless people who have felt like they've run out of options. So if you've ever wondered what's really going on when no one seems to have answers, this episode is for you. Please help me in welcoming Professor Marc Possover to the table. Thank you, Professor Possover, for sitting down with me today. And this is a complete honor for me to be able to sit in this space with you and learn from you, because you are a genius when it comes to nerves. So thank you for taking the time to sit down with me and expel your knowledge to us.
Mhm. Thank you very much for the invitation. The pleasure and the honor is for me, definitively. I think it's not a question to be a genius, but I spent simply 20 to 25 years of my life to try to understand the pelvic sympathetic and parasympathetic, also the pelvic nervous system, which is not easy.
Yeah, it's not easy, but man, it is so central to what we do. Can you explain what you do, who you are, and why conversation is going to be so important is because of what you've done in your career, but also this is your passion. Can you
Yeah.
explain a little bit about this?
So, as you said, I'm Marc Possover. Marc is my surname. I'm a French guy. I'm working in Switzerland, but I'm a French guy. I start my medical study with 15, and with 22, I was a cardiovascular surgeon. So I have a little bit a different vision of the pelvis than gynecologists. And when I start my career in cardiovascular surgery, it was in France. That time when the gynecology made a mistake in terms of bleeding, they always call the cardiovascular surgeon. And because I was a young guy in the team in the department of cardiovascular surgery, so my chef, my boss, always said, you have to go to the gynaecist, try to solve the situation. So I learned how to manage complication in the pelvis before I was able to perform even a sterilization. And then, because cardiovascular surgery was every day more or less the same, I was looking a little bit on the left, on the right, and I found the gynecology or the gynecology obstetric. And I found, it's fascinating, the gynecology, because it's not like cardiovascular surgery. You have just to deal with heart or with vascular. But in gynecology, you have to deal with women, you have to deal with life, you have to deal with obstetric, microsurgery, laparoscopic surgery, oncology, everything. And then I start my fellowship in gynecology by moving in Germany. And from there, I become a specialist in oncology and in endometriosis, because at that time, for more or less 30 years, oncology and endometriosis were once subspecialty. And more or less in Germany at that time, we were what we call in the United States pelvic surgeon. So I'm doing all kind of pelvic surgery, bladder surgery, bowel surgery. And over the year, what I was missing is when we are doing a lot of surgery, big surgery in the pelvis, we will not use what we call a high morbidity. Morbidities that need complication, and I'm not talking from complication during the surgery, like damage of the bladder, of the blood vessel. But the problem at that time, 30-40% of our patients were not able to empty the bladder after the surgery, whether we were performing surgery for a cancer or for endometriosis. And in cancer patient at that time, when you say the patient, okay, that is the price to be alive, more or less the patient accept the situation. But when you have to deal with a young woman, 25, 30 years old, she want to get pregnant, she just married, to you do a surgery, and then she have to use a catheter, that is a shame. And that's the reason why I was starting to think we have to reduce this morbidity by preserving the organ in the pelvis, which are in charge of all these different functions. And these organs are the pelvic nerves. And that's the reason why I start to focus my attention of the pelvic nerves. And for 20, 30 years, we introduced laparoscopy in the gynecology. And laparoscopy is like a microscope. So you can see the small nerve from less than 2.1 millimeter, very big of the screen. And that was the start of the neuropelviology, what I became over the year. I'm still a gynecology. I'm still doing endometriosis and oncology, but more than 90% of my work now is neuropelviology. So I'm a kind of neurologist for the diagnosis and neurosurgeon in the pelvis.
Which is fascinating because I think a lot of times, a lot of us think about endometriosis as just the disease. We don't think about it as it being a nervous system issue. Can you walk us through why the nervous system plays such a huge part in endometriosis and why this matters not only to the patient, but to the provider?
Yeah, the problem endometriosis, it's just a cause. The cause, when you feel pain during your men's bleeding, it's not because you have endometriosis in your brain. You feel pain because within the pelvis, everywhere, but not just in the pelvis, there is no place in your body where there are no nerves. And the nerves have always two functions. One function is to bring information to the brain, and one of these information is pain, but it's also information like my bladder is full, I have to go on the toilet, or I have sexual activity, or I have some desire. And the nerve will bring information to the brain down, like I want to empty my bladder, or nerve will bring even information to the pelvic organ. Now is time to get an ovulation, or now is time to get a bleeding. So, and endometriosis is just one of the causes that can induce damage or irritation of the nerves, but are not the only one. If you have an infection, if you have a myoma compressing the nerve or pathology of the same nerves themselves, the patient will feel pain. So, in endometriosis, patients have infertility, dysmenorrhea, pain during intercourse, pain during men bleeding, because the nerves are involved. Without nerve, we would not have either pain nor ovulation or bleeding, because the nerve control everything.
Right. And there's one nerve in particular that is the driver of this, and that's the vagus nerve. Can you explain the role that this nerve plays in our body, in our nervous system? Because I think something that you brought to light was the fact that it is kind of the driver in most all pain, not just endometriosis. It drives pain whether we're scratching our leg on a bush or it's, we're walking and we're having a hard time walking or whatever that case is. Can you explain that a little bit better for us and why this matters so much?
So maybe I have to explain a little bit the nerve system, not just in the pelvis. You have two kind of nerve. You have what we call sympathetic nerve, that on the nerve which command the red muscle. So if you want to move a leg, is because you have an activation, for example, of the sympathetic nerve. And behind this sympathetic nerve, you have another nervous system, what we call autonomic nervous system or vegetative nerve system. That is a nerve system we cannot control. For example, if I'm breathing, and it's no need for me to think about that, or if my cardiac is working, it's because I have an autonomic nerve system. Or for example, in the pelvic cavity, the bladder. If I want to go on the toilet and to empty my bladder, my brain is giving the information, do it. But then the autonomic nerve system is no need for me to think I am already avoiding my bladder. That's the reason why, suppose you want to empty your bladder, you go on the toilet, and suppose you have a book. So you can say, okay, I want to pee. The brain will give the information, but the vegetative nerve system will do by himself. So it's no need for you to think while you empty your bladder. You can read a book because the autonomic nerve system does that by his own. And the vegetative nerve system is the nerve system that the Chinese medicine well know. And you have two systems. You have a bad nerve system and a good nerve system. And the bad nerve system is what we call the sympathetic. It's called sympathetic in French. Sympathetic would mean nice, but it's not a nice nerve system. The sympathetic nerve system is involved in its increase in pain, in dysmenorrhea, if you have headache, if you are worried, if you don't feel good, that is the sympathetic nerve system. And on the other side, you have the parasympathetic nerve system, which is called the rest and digest nerve system. And this parasympathetic nerve system is for the well-feeling. So if you have no pain, if you feel good in your life, you enjoy your life, you can properly void your bladder, you have properly intercourse, and all these things is because you have the autonomic nerve system. And these both nerve system are in balance. So the parasympathetic, the good autonomic nerve system is, if it increases, it will decrease the sympathetic nerve system. So suppose you have pain. Pain means you have an activation of the sympathetic nerve system. You can say, I will reduce this sympathetic nerve system. For that, I will take painkillers. There is another way to say, because they are in balance, you can reduce the sympathetic nerve system, and that way the well nerve system will increase, or you will say, will increase by myself, without painkiller, the parasympathetic nerve system. And the parasympathetic nerve system, you have two systems, one in the pelvis, which you cannot control with the brain, and you have the second system is the vagus nerve. And the vagus nerve is a nerve that emerges directly from the brain, is running in the neck outside the spinal cord and go in your abdomen, and will control your cardiac activity, the lung, all the different functions. So if you are able to activate the vagus nerve in your life, you will be more happy. It's so simple like that.
But is that an easy thing to do? Which is, I think, for a lot of us, we're like, how do we do that? How do we activate that vagus nerve?
I think you have three possibilities. One is to activate the vagus nerve passively. And one very, very easy way is what we call the transauricular vagus nerve stimulation. Because the vagus nerve will send branch everywhere, some nerve fibers everywhere in the body, and some of these fibers reach the ear. And these fibers are very important because they are directly connected to the brain. So they are tense device, that means that bring very nice electricity. There is some device you bring here on the, what we call the conch, and then you can activate the vagus nerve. And for example, my patient affected by endometriosis or spinal cord injury patient who are depressive, I advise them, please, in the morning, in the evening, 10 minutes, when you are lying down in your bed, try to do a little bit stimulation of the vagus nerve here. Now there is another way, is how you are. If you're staying up in the morning and you say, oh, today is a bad day, you have high risk that it will be a bad day. If you're coming up, staying up, and you're obliged to think, oh, today is a beautiful day, I will have a blue sky. If you try to convince yourself that it will be a beautiful day, you have much better chance to get a beautiful day. And there is a third method to increase the vagus nerve is what we call the subliminals. Subliminals are audios, they are music, where in subliminals you can bring a message in a high frequency,
Yeah.
so you will not hear the message, but your brain will hurt. And in this music, which is very peacefully, you can bring the message, today it will be a nice day. You will be happy, you will have no pain. Okay, you will get your man bleeding, but you will see. It will be much better than the last month. And when you do that, it's like a kind of auto-suggestion, which will increase the activity of the parasympathetic nerve, and your day will be better.
Interesting. Is this impactful with like breath work and doing body movement if you can and things like that? Because we hear a lot about that.
Yeah.
How important is that to increasing that parasympathetic system?
Yes, with sport activity, and for that I'm pretty nice located here. I'm in Switzerland because we have the mountain, and the mountain is really swimming and hiking on the both method to not to increase the vagus nerve. Of course, if you're in the mountain and you see a sea is beautiful, it will make you happy. Then you have an activation of the parasympathetic nerve. But if you're swimming or if you're hiking, you're breathing. And when you're embracing a lot, you will induce a massage of what we call the plexus solar. And this way, you will decrease the activity of the sympathetic nerve system. And that way will increase the parasympathetic nerve system. So it's true if you're doing sport activity, running, hiking, swimming, you will feel the pain much less. And if you're thinking about a patient or a woman who are doing very lot of activity, sport activity, and usually much, much less pain during men's bleeding than patient who are sitting home. And yeah, it's simple like that. It's anatomically, activity will decrease the sympathetic nerve system. And by the way, smoking will increase the activity of the sympathetic nerve system.
Interesting. What else increases the sympathetic system? Stress, probably, I would assume.
Exactly. In principle, you have just the sympathetic nerve system is a fight and flight nerve system. So you have just to think when you're afraid. So let's give an example. Through a night, we met together on the street. It's dark, and I want to kill you. You will not start to smile. So if you are afraid from me, you have only one in mind. Go away. You will try to run. Run mean you will need blood for the muscle, blood for the heart, blood for your brain, blood from the lung. So the blood in the rest of the body will be decreased. And that's the reason why, for example, when you are affected by endometriosis and you have an overactivity of the sympathetic nerve system, you are white in face. That's the reason why your fingers are cold. Your body is cold. But when you're afraid, you will start sweating. So when you have a patient with an overactivity of the sympathetic nerve system because I want to kill you in the night or because you have endometriosis, you will be tired, you will be white in face, you will be cold, you will look for something warm. But if I give you the hand, I will feel that your hand is cold but wet. Now, listening about the night, when you have to write in the night, it's like the cat. You have to open the black in your eyes to see more light. That
Mm-hmm.
means when you have an overactivity of the sympathetic nerve system, the black in your eyes will get open. It's what we call a mydriasis. And then simply think about people in the television. When they have to go in the television, usually they have a glass of water. Why? Because when you have an overactivity of the sympathetic nerve system, the salivation in your mouth will decrease, and that way your lips will get dry. You will start nervous, your cardiac activity will increase, you will start to breathe much frequently. And all these signs you can see when a patient is coming in your office, you see she's white in face. The black is dilated. She has a mydriasis. The lips are dry. The hand is cold but wet. You see under the shoulder, she's sweating, but she has cold. If you see she's quite nervous, look here. When you see increased cardiac activity and you have the feeling she has to breathe a lot, you know she has an overactivity of the sympathetic nerve system. And in the life of the woman, the cause number one, which every month will increase, activate the sympathetic nerve system, is endometriosis.
Hmm. And what's interesting about this is that it sounds so simple and yet so complex because it's the human side of us mixed with the body side of us, like the emotion plus the body. So combining those two seems impossible to manage or impossible to like think past sometimes for a lot of us. Why is it important that we address this and acknowledge that though? Because I'm sure you see some of the patients who have severe endometriosis because you do a lot of nervous system stuff for endometriosis and sciatic endometriosis and teach neuropelviology. So you're seeing a lot of these patients who are very in their sympathetic system. How
Exactly.
how how do we regulate this as patients? Why is this important to understand and try to manage?
That maybe I would say maybe I can give you later the answer how it is important for a patient, but I would like to say first how it's important for a doctor.
Yeah.
Because when we are a doctor, we're sitting in front of a patient, we see she's quite nervous, she has a high level of stress, she's pale in face, and she explained, oh, I have pain during my month bleeding, everywhere in my body, I have shoulder pain on the right. On the right, we know it could be endometriosis of the sciatic nerve. No, 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 doctor, I have pain on the left, endometriosis on the left, not very frequent. Probably the patient have some psychological issue. And if you open the door and the patient starts, and during my men's bleeding, something is wrong. My feet are getting cold and I get pain in my fingers. That is a point as a doctor where you will say, okay. I am a surgeon, I'm an endometriosis specialist. I know that I can find endometriosis in the pelvis, but not in the shoes, not in the fingers, not in the left shoulder. Probably I have to send this patient first to a psychologist. In Europe, we have some certification center in endometriosis. And it's very important because in this certification, you have always to give the name of a psychologist. And that is exactly the point. As a doctor, sometimes probably we are pushing the patient much too fast in the corner of the psychology. And once you understand the sympathetic and parasympathetic nerve system, then you will understand that all these complaints of the patient are part of the same disease. And the disease is the irritation of the pelvic sympathetic nerve. And endometriosis may be one of the causes, but it's not the only one. And that is a little bit my fight I had actually. Over the last 30 years, I was fighting for awareness, increase awareness of endometriosis, not just in patient, but also in doctor. And now I have the feeling we are going a little bit too far. When patients have pain, it's endometriosis, that's it. And that is too easy. When a
Yeah.
patient have an issue with the bladder, issue with the rectum, they can experience exactly the same pain and to say, okay, let's do a laparoscopy and remove some endometriosis. Maybe you will find endometriosis, but it's not the proof that the endometriosis is the main cause of the pain.
Right.
And now for the patient, I think it's very important to be aware of this sympathetic nerve system, to know as a patient, I'm not crazy.
Yeah.
It's part of my disease. It's part of my pathology. Once again, if I have pain in my left hand during my men's bleeding, it's not because I have endometriosis in my left hand, but because I have an overactivity of the nervous system. And that is exactly what I mentioned. How many patients affected by endometriosis have pain, have headache during men's bleeding?
Yes.
You have not to look for an endometriosis in the brain. It exists. But it's so certain. I never saw that in my life. But if you have an overactivity of the sympathetic nervous system because of an endometriosis, for example, in the pelvis, in the ovarian, that will induce headache because of an overactivity of the sympathetic nervous system. And that's the treatment is not to give you antidepressive of some painkiller for your headache, but to treat the cause of the overactivity of the sympathetic nervous system and to remove the endometriosis or maybe another cause. And one of the second main cause in women to have an overactivity of the sympathetic nervous system is what we call outlet obstipation syndrome. The bowel is much too long. And you know, there is a simple trick. I always look the fingers of my patient. When a patient has very long, thin finger, you can be sure that the bowel is very long, very thin, and is making kinking inside the pelvis. And then the patient has a bloating bowel with bloating abdomen, pain in the back. Sometimes this pain even go down, radiated in the leg, not in the back of the sciatic nerve, but in the front or in the inside of the thigh. And that is what we call outlet obstipation syndrome. And it will induce the same pain like in endometriosis, but not just during men's bleeding, but in some patients every day, depending from food, what they are eating. So that is exactly my message. Endometriosis is only one cause. There are other causes.
One of the things that you and I had talked about previously was the fact that it's not comorbidities. They're all one thing. It's all one thing. And I think
Absolutely.
it's hard because we compartmentalize. We got to solve the endometriosis first, then we got to solve this issue, and then we've got to solve that issue. It's an overwhelming thing. And we're seeing that there's a lot of correlation between endometriosis and some of these other conditions.
Exact.
Why do you think that is one condition? And can you explain that just a little bit for us?
Yes, the problem is the way we are thinking in medicine, because we are thinking in small area. So when I'm a gynecologist, I'm dealing with the uterus, the ovarian, the tubes, the vagina, that's it. So when a patient is coming and said, well, Mr. Possover, I have pain every month during my band bleeding. Okay, could be endometriosis. Yeah, Mr. Possover, I have another problem. I have to go 20 times per day on the toilet to pee. Oh, that is an issue with the bladder. That is a urologist. And the urologist will look for a cause, like I'm looking cause for pathology of the genital organ, like endometriosis. It will directly look for a cause that may affect the bladder. So an infection, interstitial cystitis, or something like that. And if the patient said, and I have a third issue, I have irritable bowel, then you send the patient to a gastroenterologist and will say, let's do a coloscopy. Your mucosa is a little bit red. You have some chronic inflammation of the bowel. And then we say, oh, this patient is affected from endometriosis and with comorbidity, bladder, rectum. The patient go to the urologist. The urologist will say she's affected from a bladder issue with comorbidity, endometriosis, and irritabilis bowel. And I say no. The pelvic autonomic nervous system is the same for the bladder, for the rectum, and from the genital organ. So it's not a comorbidity, it's one pathology, the irritation of the sympathetic nervous system. And that's the reason more or less all patients affected by endometriosis, whether it's a deep endometriosis, an adenomyosis, or pelvic endometriosis, peritoneum endometriosis, they will all experience that during men's bleeding they have pain, they have to go more frequently on the toilet to pee. It's easy to say, you have the next bladder infection, I will give you some antibiotic. And at the same time, they will say, oh, during my men's bleeding, I have diarrhea. Oh, let's do a coloscopy, maybe you have endometriosis of the rectum. Maybe. but maybe it's an irritation of the pelvic nerve, which are in charge of all these organs. And then the autonomic nerve system, we have not to consider it as you have a pelvic, an abdominal, a brain, a spinal cord autonomic nerve system is one autonomic nerve system. So if you have an irritation in the autonomic nerve system in the pelvis, you will have an activation of the autonomic nerve system in the whole body. And that's the reason why you feel tired, you are not good that day, you have a headache and all these symptoms. So one pathology is a pathology of the nervous system.
Yeah. Which would explain why there's people who have surgery. They have good endometriosis surgery, but they have reoccurring pain or persistent pain because they haven't dealt with the nervous system, or there's something else going on with the nervous system. Is that something that you find that we ignore a lot of? And that's why I think there's risk in reoccurring surgeries by not addressing that.
Yeah. Also, in the past, when I perform a surgery and the patient has still pain after, the question was maybe I didn't remove everything. First. Secondly, this colleague from this hospital performed a surgery is not as good as I am. For sure, he was missing some endometriosis. Let's go the next surgery. Or maybe I was thinking, the patient is getting a lot of hormonal treatment. Maybe the on-side effect of the medical hormonal treatment. And it's true that if patients are getting a lot of progesterone, one of the main side effects is constipation. Another one is depression. So it's easy to say the patient is depressive because a side effect of the hormonal treatment. But as a neuropelviologist, I can say maybe it's because of the overactivity of the nerve system. And it's very frustrating when you perform a laparoscopy, and especially you will not find a lot of things, maybe a little bit endometriosis. You have to do your job. You have to convince the patient that you found endometriosis, because today patients want to know I have endometriosis. So maybe you will make a beautiful picture from a little bit endometriosis. And then after the procedure, you will say, yes, you have endometriosis. If you're honest, you will say, I don't find a lot, but we know that endometriosis, the intensity of the pain is not correlated to how many endometriosis you see. And it's true, maybe a little bit endometriosis will induce an explosion of the sympathetic nerve system, depending also in the situation of your life where you are. Suppose you want to get pregnant in 3 years, you don't get pregnant, you are becoming more and more frustrated, nervous, that will increase the sympathetic nerve system, and a little bit endometriosis will increase even more activity of the sympathetic nerve system. But we have also to think another way. The neuropelviologist way is to say, we did a good surgery, patient has still the same pain, maybe I made the wrong diagnosis. She have endometriosis, but the main reason of the pain maybe is not the endometriosis. It's maybe something different.
Yeah. Which we've talked a little bit about this offline a little bit, but the fact that there's a lot of providers that lack that curiosity, that they look inside the box, but they don't look outside the box. So, this is a call to those providers, to any provider that is listening. It's so imperative that you look out. You don't even create a box to look out. You have a base, but then you explore and become curious, which is why when we were talking, something that you said to me that stuck out, and I will expound on this a little bit, but you said, I have never had a box. Why? Why have you never had a box? And this is where we're at, is exploring the neuropelviology aspect of endometriosis. Why don't we have this box? I
The answer is maybe because I'm a French guy. No, so where I am, if I try to do my best to treat a patient, to help a patient, and I fail, so one possibility is simply to say what I said. I had the wrong diagnosis. I have to think out of the box. But the reason why I really start to think in neuropelviology is nerve. It was a little bit another one. It's not because I'm a French guy, I want to think about out of the box. But when I say which kind of mistake I was doing, I performed a great surgery. I was very proud of me. Went home, said my wife, wow, today I was good. I did a good surgery. And 2 weeks later, I see my patient and she said, yeah, I have difficulty to pee. I got a bladder infection. What I have to do? Oh, you have to use a bladder catheter. So I start to focus my attention on the nerve because there were a need to do that. And in medicine, there is two ways to see. You can see the positive, you can see the negative. And in my opinion, if you want to help patient, you have to focus your attention not on only what is positive, but you have to try to understand why she has pain. You have to look for problems. And when I was looking for why it is like that, that is the point where I understood for 30 years, 25 years, nobody is dealing with the pelvic nerve. I would suppose we have colleagues neurologists that know everything about the nerve. No, they don't know about the pelvic nerve. I made my medical study. I never heard during my medical study anything about the pelvic nerve because it was difficult for everyone.
Yeah.
There are so much nerve, nobody have really had the understanding how really it works. And when I was thinking, if there is a pathology of the nerve, we have neurosurgeon. But neurosurgeon are doing brain surgery, spinal cord surgery, or maybe surgery on the nerve, which they can access. But neurosurgeons are not trained in the pelvis. So for 25 years, I was sitting. When I'm really honest, I will give you a little bit more intern personal thought. My wife had problem after vaginal delivery. After delivery, she developed severe neurological problem. So we went together to neurologist, neurosurgeon, urologist, talk, nice talk. But finally, we were sitting home together without any solution. And that's the reason why I said, okay, it's a big black box in medicine. Nobody really know what is going on in this pelvis concerning the nerve.
Right.
So somebody have to open the door. If you talk with general surgeon, visceral surgeon, who are doing rectum resection, maybe 2-3 rectum resection per day, every day, the nerves are few millimeters away from where they perform the surgery. But most of the general surgeon never saw the sacral nerve root. The general surgeon are becoming aware about the parasympathetic nerve, pelvic nerves. And they are starting also with nerve sparing technique is a good thing. But for 25 years, when surgeon came in my OR for the bowel resection, I said, never, I will do that because you will cut my nerves.
Yeah.
So I start to look on the nerve because I understood there is a need to do that.
Yeah. Which is why, it's interesting. I had talked to some doctors, gosh, a while back, talking about the importance of understanding neuropelviology, understanding why this is so important for them to understand. And they didn't understand why it was important for them. And I think that was so frustrating as a patient to hear, I don't understand why that's important. Well, it's important because I care about my nerves. I care about what's happening in my whole body, but I shouldn't be the one that has more information about how this all plays out. I can't help myself. I'm not educated to do that, but maybe I am. Maybe I am educated to do that. But I think that one of the things that was frustrating was this is so important to understand for them. Because if you understand the basis of nerves and the function and nerve sparing, you could really help your patient. It's about patient care. It's about caring more about the long lasting outcome of your patient, not just the here and now. And I think it was really frustrating for me to hear that. And I was a little discouraged, but I think I'm also encouraged by the fact that patients can make an impact on the providers by saying, no, I demand more. I'm not going to settle for,
We have some
cutting my nerves.
difficulty with the
Like,
connection, I
ask the
think.
questions. Do you do nerve sparing? How do you do nerve sparing? Like, those are questions now that patients, I feel we have to be educated on. And that's why you and I talking about this today is so important because I feel like we're at this crossroads where patients are becoming more savvy and they're pushing providers to become more engaged.
When you said it's frustrating to see that for quite a lot of colleagues, they don't want to understand neuropelviology. The problem, I don't think that they don't want to understand the neuropelviology. I think a lot of colleagues don't know what it is, neuropelviology. And that is exactly what you mentioned. Neuropelviology is not just nerve sparing. It's also understanding the nerves. And if you follow me, you saw that this week I made on the YouTube, I made an education on endometriosis, and the topic was the Luna technique. So the Luna technique is a surgical procedure where we cut what we call the sacrouterine ligament. So you cut the nerve, and then the patient have less pain. Yes, if you cut the nerve, the patient will have less information going up to the brain, information, I have pain. But you remember what I say, the nerve are working in both directions. So you cannot just cut the nerves that brings the information of pain to the brain. You will cut also nerve going to the vagina, to the uterus. And when we think about the sympathetic or the parasympathetic nerve system, the parasympathetic nerve system, just in terms of fertility, it is in charge of the ovulation. He's in charge of the motion of the tube. He's in charge of the motion of the uterus. He's in charge of the opening of the cervix. He's even in charge of the motility of the spermatozoid in men. So suppose you perform a Luna technique and you cut a lot of parasympathetic nerve system. Maybe you will have a negative impact on the fertility of the patient because you will maybe reduce the chance to get ovulation. You will reduce the motility of the tube. Maybe the patient will develop an increased risk for ectopic pregnancy. And maybe you will change the mobility of the uterus. That is something we know. When you are performing surgery for deep endometriosis of what we call the sacrouterine ligament, then you cannot spare all the nerve. You have to remove the disease. And we know that in patients, when we perform a surgery for deep endometriosis, it will be more difficult for the patient to get a vaginal delivery because of the cutting of the nerve. In a lot of these patients, after previous deep endometrial surgery, they will develop a dysfunction of the cervix, and the cervix will not get open. And I think a lot of patients will recognize themselves when I said, you got a surgery for deep endometriosis, you got pregnant, and then you were staying 2-3 days in obstetric department. They tried to give you a lot of medication to open the cervix. It didn't happen, and finally you got a C-section because the cervix didn't get open because of the cutting of some of the parasympathetic nerve of the cervix. So you see how the nerve are linked to everything, to everything.
Yes. And this is why it's so important for people
Yes.
to learn about this. This is why not even just the provider, but the patient to understand. Because if you've had surgery in the past, to understand why some of these struggles are occurring, I think it's so important. I wish I would have known some of these things prior to some of my surgeries, but hindsight is 2020 and I'm moving forward knowing this and helping others. And that's why I'm doing what I'm doing because of things like this. The more we learn, the more educated we are, the better decisions we can make, the better we can advance healthcare for women, for endometriosis patients, for all those patients who are dealing with other chronic illnesses, to help us navigate life that is more fulfilling and have a better quality of life. Like that is the whole message here, right? Is
Yeah.
understand.
I think you cannot say we need education for the doctor and not of the patient. Or contrary, you need education on both. We are partner. When we
Yes.
are dealing with your body, even more when you're in the war, you are on anesthesia, you have to trust us. We have to trust you as well. So we have to be partner on that. And when I start for 30 years with endometriosis, We know as a doctor the name, but we didn't have a lot of knowledge about endometriosis. Endometriosis was for 30 years a benign disease which is very painful. That's it. So wait that until the patient will get 1, 2 baby, and then you will remove the uterus. That was endometriosis. So we have to educate ourselves. But I think the key will really change the story of the endometriosis over the last 20 years was the education of the patient.
Agree.
And that is a shame. But when I was for 2, 3 days in Bangkok, we were talking about deep endometriosis and rectum resection. And then we were talking, wow, we got a great evolution over the last 20. We start to perform bowel resection. Now we have shaving. Now we have discoid resection. Now we have robotic surgery. We have such an improvement. But if you see the data out of the gynecological box and you go to the field of the general surgeon, in your country, in the United States, you have the College of Surgeons. I think it was 2015. They perform a paper, a big paper about the situation of bowel resection for endometriosis in the United States. And definitively, the number of patients who are getting this procedure increase in the United States. And in this paper, in this study, if you see, the main age is 43. And then when I'm seeing that, I said, wow, I don't understand. Because endometriosis, the rectum takes 10 years to develop. So if we are doing more and more bowel resection for deep endometriosis, because we are doing less and less early diagnosis.
Mm-hmm.
And that is a big mistake on our side. And secondly, I always learn, or my experience is, the more the patient will go in direction of the postmenopause, don't be that aggressive. So usually in patients more than 40, I don't try to do bowel resection. So if you see this study from the general surgeon, you see more and more bowel resection, and the mean age is 43, I think. That means some patient with 78, 48, 49 are getting a bowel resection. That is insane. That is a problem. We need education of doctor, but patient need education as well. If something is wrong and you have the feeling maybe I could have such kind of things, and the doctor said, oh, you have deep endometriosis, but bowel surgery is quite dangerous. Wait and see. No, don't wait and see, because surgery is like a vaccination. You have to remove the deep endometriosis before it starts to grow within the rectum.
Mm.
And that is my main message. If it's deep endometriosis, as a gynecologist, we have not to wait. We have to do before it will induce further damage. And that
Yeah.
is really a problem in gynecology. Normally, if we are able to increase such an awareness, normally the incidence of bowel resection should have to decrease, and it
Right.
increase. So something is going wrong.
Yeah. Well, I think too, teens with endometriosis are being dismissed as it's not bad enough yet, or wait until you're older. I mean, the things that I hear, and there's a lot of providers that are scared to even touch teens with endometriosis. Not obviously not the expert side of things, but the general GYN who don't typically do just endometriosis, they're afraid to send teens for surgery here a lot of times.
But they are probably correct to train in this surgery or train to manage endometriosis.
Right. Right.
It's not, it have not to be a question of ego, but
No, right.
it's once again, we have to be partner altogether.
Yeah. And I will tell you as a patient, it can be very hard to continue to try to convince your doctors to keep exploring. And that's where you see the fatigue of patients, where you see the patients are like, I don't know what else I can do. And they're seeing, 6, 7, 8, 9, 10 doctors before someone actually says, I believe you. Let's do something about this. Let's explore it. We have to keep going as a patient, but as providers, just sitting and listening, you can tell a lot. You don't even have to, do a pelvic exam to hear their pain. It's
Exactly.
just sitting and listening and looking.
And looking the face,
Yes.
like we learned today.
Yeah, and you know what's interesting? So, but I'm going to tell you this because this is as a patient, this is what we've talked about. A lot of times when I go to see a doctor to be believed, I won't wear makeup. I will look a lot more rough. I won't put myself together because then I feel like they will believe me more than if I'm put together. And that's a sad statement.
But I think it's not just a question of belief, it's also a problem with the medical system. So I don't know how it is in the United States, but if you're in Switzerland, you will be paid by the insurance for a consultation from 15 minutes, no more. And to deal with patients with endometriosis, sometimes it takes 1 hour. But as a doctor, if you're doing your job, and suppose you're an expert in endometriosis and you see every day really big case of endometriosis, at the end of the month, you will be a poor doctor. Because if you see only 5, 6 patients per day and not what the insurance expect from you, maybe 20, 30 patients per day. So that is really a problem. The doctor who will perform a good job, you know what I mean? It's not fair. And that's the reason why I like very much the system, for example, like in Denmark, where you have really center of endometriosis. And then they're dealing just with endometriosis is correct. And I think that is a good idea. I don't think that everybody has to be an expert in endometriosis or an expert in neuropelviology, but at least in diagnosis.
Right. And at least a basic understanding, I think, is helpful, right? Understanding the anatomy is helpful, understanding the role that nerves play in our body. I'm going to shift gears a little bit because this is why I think understanding the nerves is so important. We've talked about the role they play for endometriosis, but you're exploring something more. And this is why I want to just drive home a little bit more how important nerves are to our body because you're putting the connection between nerves and the spinal cord. Can you explain why this is so important, why the research and how you're coming about this? Because I think it will help a lot of us understand the role that nerves play beyond endometriosis.
So if you want to explain me a little bit more the neuropelviology beyond the gynecology, yes, in neuropelviology, we are dealing with tumor of the nerve, dealing with entrapment of the nerve. And there is one condition, you mentioned it, is spinal cord injury. Because in a lot of spinal cord people, you have the damage at the level of the spinal cord, but the nerves which control the legs in the lower part of the spinal cord. So these nerves are not controlled anymore by the brain, but they are still working. And that's the reason why a lot of paraplegic or tetraplegic patients have what we call spasticity. Spasticity, that means the nerve below the spinal cord lesion are still working, but not the proper way. They are not getting the right information. And that's the reason why in the field of neuropelviology, I developed what we call the Lion procedure. Lion procedure is a technique how to bring stimulation electrode to the pelvic nerve. So the pelvic nerve for the bladder, for the genital organ, for the legs. So for
Mm-hmm.
the capability of staying up and walking. And that is one of my work as a neuropelviologist. I'm doing surgery in men, despite I'm a gynecologist, because most of the spinal cord injury people are men due to traffic accident. And I bring in electrode to the nerve to recover a capability of staying up and to walk with crutches. We have now more or less 150 patients. We perform surgery, and 70% are able to walk at least 10 meters. The best one, even 2.5 kilometers. So you see that is neuropelviology, and that is the reason. A lot of gynecologists think neuropelviology is not just nerve sparing. No, no, no. That is just the small door we open for 30 years, for 20 years. Neuropelviology is much more than that. It's the treatment of children with spina bifida, it's the treatment of people with multiple sclerosis, with polyneuropathy, all the pathology of the pelvic nerves. And of course, we have to discover a lot because we are not at the end station. I think The knowledge we have about the functionality of the nerve, pelvic nerve today will be probably change a lot in 10 years.
Yeah.
But for that, we have to look on these nerves.
It'll change because of people like you who are willing to explore it. And I think there's, doctors coming to your courses and learning more about it. And these are the changing faces of neuropelviology. They're going to be the change in neuropelviology, but not just neuropelviology, I think across the board for medicine. I think these are the very curious doctors who are
Exactly.
going to push boundaries and push back on the systems that have kind of put them in a box. And I'm really excited to see that.
These doctors are like my metastasis, you know. If you will talk in oncology, they are metastasis. And I always tell them, you know, when you have a patient affected by a cancer, usually not the primary cancer will kill the patient, but the metastasis. And that is exactly the point. I don't see that I will see neuropelviology becoming really a university subspecialty, but it will. My metastasis, they will do that. They will achieve that. They will see that the neuropelviology will be behind gynecology, urology, another recognized specialty in the pelvis surgery.
Yeah, it's exciting to see. I was just at the Endometriosis Summit and met a lot of these doctors, and they are fantastic. And they only speak of the utmost respect for you and the work that you're doing. But it's so interesting to see the things that they are exploring and looking at and challenging each other with and challenging other providers with and telling the patient, talking to the patients and educating the patients. And they are a class all their own, and they are fantastic and just great humans. They're not just great providers, they're great humans. Some of the best.
And they have time. They have time. And you know, when you're 30 and you discover such a word like neuropelviology, it's fantastic. You open a door from a mystery. It's wonderful. When I see some of my young fellow from Sao Paulo or from Mumbai, these young doctors, they are 30, 35, something like that. That means they have still 30 years to explore the field, the mystery of the neuropelviology. It's fantastic. I'm a little bit jealous. I open the doors, I will go inside, but that's the way how it works.
Yeah, and that's how it should work, right? That's how we should continue paving the way for future generations.
And they have to be better than I was. That is the
Yeah.
point. A fellow have to become better than the master. It is like that. Otherwise, I would do something wrong.
I love that. I love that you see it that way, that it's not about the ego, it's about the continuing of that education. And that's what's going to change.
Yeah, but that is clear. Otherwise, the day I will die or get retired, neuropelviology will disappear with me. No, I don't want that. The young guy, they will have to promote the neuropelviology in the rest of the world. And really, with the Eisen is the International Society of Neuropelviology, really, we are succeeding very slowly, quite more or less in the shadow. We are not going on the street and making a lot of noise. But now we have more and more colleagues in South America, a few colleagues in the United States. Now we are becoming more and more in India, in Asia, in Middle East. So everywhere you have small young guy who start to let grow the neuropelviology in their own country, and that is beautiful. It's amazing to see that.
Yeah. Talking to Dr. Mings is always like one of my favorite things to do. He's one of my favorite humans to talk to because I learn from 5 minutes of sitting down with him every single time. His wisdom and his humility behind it just every single time. One of the best guys out there, in my opinion. And it's always fun to just sit and hang out with him, which I get the privilege of doing when we're at the summit. So it's true. They're great people and curious, and I love that they look circumspect. They don't look straight ahead in this narrow box. It's very circumspect. They're always looking around. They're looking at seeing correlations. They're looking at, different ways of addressing not only the disease, but the diseases that like to accompany endometriosis. It's fascinating every single time, and I love it.
That is the beauty of the life, to have an open mind in all direction of the life, not just in medicine.
Yeah.
You have to
Yeah,
be curious in
absolutely.
life. You have to be curious in life.
Yeah.
I remember a very nice word from Einstein. Einstein said, innovation or vision is much more important than knowledge. And a
Mhm.
vision is born from curiosity.
Yes, I love that. And I think that is like my life motto, to always be curious about what's next and what I can learn more from. Looking forward and exploring curiosity, what are you excited for that is making you more curious?
You know, when I was a young boy, I was reading Jules Verne, and Jules Verne, he sent the people on the moon. So it was curiosity of that time. Today is reality. For me, my curiosity is what I call in-body stimulation. I have a strong belief that in the future, we'll try to treat, so to avoid disease and maybe even to treat a lot of disease by using neuromodulation of the autonomic nervous system. And that is exactly the point. You know, I mentioned you to have stimulation here of the nervus vagus in the hair. I told you 10 minutes in the morning, 10 minutes in the evening. But maybe it would be nice to have a stimulation within the body that make you happy all the day, all the time. I'm quite sure that in the future, in maybe 10 years, 20 years, we will have electronic in the body. You know, for 20, 30 years when I was a young boy, it was a 3 million guy. You know, it was in an American movie where guys got some electronic in the body. He was able to run more faster. He was able to do everything much better than with a normal body. And I think really we will go in this direction. I don't think even, I'm sure we'll go in this direction because last year we had a Congress of the Horizon in Paris, and we invited a guy, an engineer dealing with such kind of a device which we can bring inside the body. And he said, we have already all this device. It's just a question when we will get an ethics committee and to start to bring such kind of device in the body. So suppose I have the opportunity to have a continuous stimulation of the vagus nerve somewhere in your body. The vagus nerve is in the abdominal cavity. There it would be easy to bring a device there and to stimulate. I will make you happy. You will have less problem. You will maybe get much easier pregnant. You will have less pain during men bleeding. So I think it will go in this direction. And you know, I think the neuromodulation will have also an impact in endometriosis
Mm,
because when you have endometriosis induces a lot of adhesion in the pelvis because endometriosis is an inflammatory disease within the pelvis. And there is something what we call TNF factor, tumor necrosis factor. They are factor which belong to the inflammation disease within the pelvis. And there is clear evidence that with stimulation of the vagus nerve, we have an anti-TNF factor action. So we can decrease the inflammation within the pelvis by using the vagus nerve stimulation. And from the medical aspect, actually there are some medication pills which will come on the market to decrease the level of the TNF, of the tumor necrosis factor. My thought will be, why not to do that with neuromodulation, which will have much less side effect,
right.
and maybe
Right.
in the future. And that's the reason why it would be nice. I think with stimulation of the transauricular stimulation, I don't say that we will be maybe able to treat endometriosis and maybe to avoid surgery, but maybe decrease the level of pain. And that is also something, because when you take an hormonal treatment or painkiller, you have no impact on the activity of the endometriosis. You decrease the pain level.
Yes. Decrease that flight or flight.
Exactly.
And maybe we can decrease not only the pain, but the amount of endometriosis that invades the body.
Absolutely, absolutely, but because there is clearly scientific evidence, but that by stimulation of the vagus nerve, you will increase the immunity, the immune system. And endometriosis may be a kind of immune dysregulation. White cell from the uterus gets the capability to grow within the abdominal cavity on the periton or some maybe because locally there is a depression of the immune system that allows the cells to develop and to grow at that location. Maybe with an increasing of the activity of the parasympathetic nerve system, we will decrease the ability of this nerve to grow, to implant within the abdominal cavity.
Yeah.
So why not?
Why
Let's
not?
see the future. Absolutely.
Well, and it's, I mean, gosh, you think about even, you mentioned this earlier, and I'm kind of backpedaling a little bit, but you mentioned like the pregnancy is harder when we're in such, high fight or flight. That's why, it's interesting that I see a bunch of people who during their adoption process or during, wanting to, maybe they're going to have surgery for a hysterectomy. And so they've kind of relaxed and all of a sudden they're pregnant,
Mm-hmm.
and I think that's only like, that's not happened for everyone. And I don't want to put that across the board. But what I'm saying is there's something to down regulating that sympathetic system and
Mm-hmm.
upregulating that parasympathetic system of rest and digest,
Mm-hmm.
taking a breath. And that's what, we talk about the breath work, we talk about the stimulation, and this all plays a part in how we manage this disease. And I think a lot of people are always curious as to how can I help manage my endometriosis? How can I help manage my pain? This is an avenue which everyone can explore. It's not
Exactly.
just surgical. It's a practical way for us to be able to manage pain, to manage potential, you know, increase in the endometriosis within our body. I don't, you know, the stimulation, the breath work, the food, the stress, all of
Exactly.
these things play a part in
No
that.
side effect. There is a simple thing. When is the best time in life of a woman to get pregnant? In the past, always everybody said the best way is to get married and to go on honeymoon. Why in honeymoon? Because you have an overactivity of the parasympathetic nerve system. Your body is full of butterfly. You are happy, happy and happy. That increase the parasympathetic nerve system. And in the past, old lady always says the best way to get pregnant is to go on honeymoon. Try to
Yeah.
get pregnant in holidays. Yeah, because you have an overactivity of the parasympathetic nerve system. So science is coming to reality what people in the past were talking. So it's not out of the blue. It was experience to see when you're happy, you're getting much easier pregnant than when you're unhappy.
Yeah.
And
Yeah.
exactly to change these things is not like to take a hormonal treatment, take a pill or a surgery. Everybody can try that without side effects. Stimulation of the vagus nerve is an easy thing. You found that everywhere on the internet. It's easy.
Yeah. It is. And we have to make time for it. And and that is one of the things that I feel like a lot of us are constantly trying to find solutions, trying to find ways to cope and manage. Sometimes it's being quiet or stimulating in other ways. And I have found myself to struggle with this a lot because I'm a busybody, but my busybody gets me in trouble. Because then it puts me out for a couple days. So I think it's important. After time learning about this, that's something that I have really taken to heart is like, how do I do this practically in my life? Because we talk about endometriosis being a whole body disease and a whole life disease. It truly is. You can help your whole body and you will help the whole disease.
Yeah, and don't say that by stimulating the parasympathetic nerve, maybe you will treat your endometriosis, but maybe you will make your life a little bit easier and the life of your family as well,
Yeah. Oh,
which will do will much easier.
yeah. I love that. I love that this is a practical tool. Like you're not just a surgeon, you're more like a therapist at this point. You're a life coach. That's what you are. You're a life coach. Professor Possover, thank you so much for taking the time to sit down with me. I am leaving with my cup full today, just talking about this and learning from you. I'm excited to see where neuropelviology goes. I'm excited to see where you're able to have your fellows go and to teach them to branch out. Much like a nerve, if you ignite it one place, it'll spread out in other places. And that is where your wisdom and passion and knowledge go. So I just appreciate everything that you're doing for so many people. But for sitting down and talking about this and bringing this to light is going to make such a huge impact for so many. So thank you so much for doing that.
I have to thank you for this opportunity and your kindness, because it's not easy. It's not easy. My first podcast, but it makes me happy. Yeah. If we can do, and but the truth that is what we call the Hippocrates oath, to do everything for my patient. I promise that. And what we are doing here is promoting education of patient. Patients have to know their own body, and if they know their own body, they will even better know which doctor is the right one to help them or not.
Yes, it's so true. Knowledge is power. Knowledge is power. Yeah, absolutely. Well, until next time, everyone, continue advocating for you and for others.